Welcome, Gustavo, this night. It's a pleasure to have you here with this awesome team in Joint Therapies. And I am going to shut down my microphone and my camera, and please, you can go on.
Okay, great. Thank you guys so much for inviting me to talk a little bit about this. Joint therapy is something I have been studying, for quite a while. I did my master's on cartilage repair, my PhD on cartilage repair, and I had the chance to do sports medicine residency here, where we do a lot of treatment of musculoskeletal and joint disease is one of the biggest, topics. So let's start and go ahead. First, I want to just say some disclosures. So I have no financial disclosures to make. I just want to point that, the review I'm doing today is not extensive, it's systematic review. So I have selected papers that kind of represent my opinion and my clinical experience. So there is always no chance that one paper that, maybe point something different have been left out. No, I try to do my best to cover all the bases and discuss as much as I can all the papers that all the topics. It kind of use a lot of evidence-based medicine for us to be able to discuss these topics tonight. Also, I try to classify the level of evidence we have for each of the topics and questions. And the point, we don't have a level of evidence for musculoskeletal research in horses. So different than humans, that level of evidence is well established. We don't have that in horses. So I kind of come up with some idea based on what they use in human studies. So just to give a quick introduction on how I classify the level of evidence. It was similar to what's done in humans. So highest level of evidence, you're going to have meta-analysis, systematic review, and randomized clinical trial. That's what I classify as a strong evidence. Controlled retrospective cases or experimental studies in horses, I call moderate evidence. A randomized clinical trial in other species, and I use the human as a base. Science, if you want to see function, human is one of the few models can give you improved analysis of function and cases series. And a weak evidence, or the bottom of the pyramid, would be in vitro studies or experts' opinions. So following that, I just want to do a brief a review or pathophysiology, and I think Dr. McRae does an amazing job making things simplifying things for us to kind of keep the clinical mind around the osteoarthritis. And I think the way that he simplified this is just basing that joint OA happens when we have abnormal stress in a normal cartilage or a physiological stress in abnormal cartilage, right? So this supraphysiological abnormal stress can be a single impact injury, like post-traumatic OA, or it can be the repetitive traumatic injury as well. So here's another chart that from Dr. McRae's book, and that's trying to summarize all the process going on the joint disease on OA. And that's very interesting because that's kind of summarize all the tissues that's related to joint OA, right? We have synovial membrane, we have cartilage, we have subchondral bone, and we are always looking for the inflammatory mediators that is released from the synovial membrane, from the cartilage, and from subchondral bone. And we're looking for the also for the proteases that's being breaking down the cartilage. So that's kind of how the cartilage interacts, and how synovial membrane interacts with cartilage and subchondral bone. And therapeutically, that's basically what we target. Is we target the inflammatory components, and we target the proteases in the joint to keep the homeostasis. So another concept that I think is very important for us to discuss here is disease modify osteoarthritic effects of a drug and symptom modify. So we can classify this in two different ways. The disease modify is any effect that a drug is there that's prevent cartilage degradation or prevent pathological changes of the synovial membrane, or like the whole structure of the joint. While like symptom modify is basically alteration of the clinical presentation. So basically how much painful is that for the animal, right? And one thing I think it's at least the way I approach clinically is we have these drugs that have like some disease modify effect, some drugs that has like more symptom modify effect, some drugs has both. So how I choose things, and I think a lot of these things are related to the disease progression, right? So in the beginning of the progression, like the disease modify effect for me is probably one of the most important factors from the drug. But as much as you start to know the disease progression start to be more severe, the disease modify effect of a drug for me is not as important anymore, because there is no more cartilage left. And now I really need to pay attention, like how much comfort I can give to that horse, right? So far, we didn't figure out any way to regenerate cartilage. So if the disease process is too severe, there is no cartilage left, I don't see a point to use disease modify, drug in that case scenario. And that's kind of like where, like, maybe this approach is a little bit different from what we do sometimes, like how we approach that clinically, especially because when we talk about biological therapies, right? Biological therapies have some interesting disease modify effects, but they're usually more expensive. So we tend to leave that product more to more severe cases, and that's what I'm trying to point here is maybe we should change that approach, and maybe we should start to use biological therapies a little earlier, and maybe whenever like the case is too severe, we have like maybe other therapeutic tools that's not as regenerative, but it's still giving the horse a lot of comfort. So it's just the way I try to think clinically. So here's another picture from Dr. McRae book, Joint Disease, and I think it's really nice. He's trying to show what's the disease progression. So in top here we have a normal cartilage, normal synovial membrane, and the cartilage intact, and the disease progresses with inflammation of the joint, with synovial membrane being inflamed, but the cartilage is still intact. And following the progression, you start to see some superficial fibrillation of the cartilage, and that just tends to progress until we have cartilage erosion all the way to subchondral bone, right? So we just need to understand that there is different. We should use different therapeutic approach for different stage, and that's kind of like another thing you are lacking on the literature, is to know when to use what, right? Like we have kind of like a little bit loss of formations everywhere, but I don't have a clear cut to know when I should use corticosteroids or when I should use biologic therapy or any other drug that you use to that spectrum. So that's something you're gonna try to explore a little bit on this presentation and discuss, and see what you guys experience as well. So I'm gonna start with the intrarticular corticosteroid, and that's probably the part of this presentation that I spend most of the time. And for me, it's really easy to justify that, just because it is still being probably the most common therapy I use to treat joint disease in horses in these days, right? So on my clinical work, most of the horses that I treat with joint disease, they will receive a corticosteroid injection. And there is now a small portion that's going to go be, biologic therapy or, hydrogel or something else. So I just want to get as much information as you can get from probably the tool that we use most, and, go through other, therapy as well. But I definitely try to spend more time to understand better corticosteroid therapy. So some of the questions I try to answer is, do we have evidence that corticosteroids prevent cartilage degradation in vivo? And do we have evidence that corticosteroids affect normal cartilage metabolism? Do we have any evidence about higher doses have more beneficial effects? Or, if different chondroprotective and chondrotoxic effects observed in some of the corticosteroids are dose dependent? Or, if, I hear that a lot of time, oh, this horse are going to use methylprednisolone because, I want to have I think it's more potent. And I'm not quite sure if you have these answers, and that's what we're going to go over, like, now, the discussion now. So before start discussion with corticosteroids, I think it's important just review the carpotypo model. So that's a model to induce osteoarthritis in horses. And, there is pros and cons on this model. What I think it's very interesting for us to look this model is there is a lot of drugs or interventions that have been tried, have been tested in this model. So that's make a little bit easier for us to compare drugs or interventions. So it's a well-established model. We can look like symptom modify, so we can see pain improvement. You can see, the progress of disease, also improvement on the progress of disease. I do think it's mimic well, like the post-traumatic OA, especially for race horses. So people that work a lot of race horses definitely, see a lot of these kind of OA, developing clinically. However, it's not a naturally occurring disease. It is an acute and severe model. So if you're looking for something more subtle, more, if not as big as impact, look for more subtle benefits, maybe that's not actually, a perfect model. Does probably not mimic the slow progression of OA in other sports horse. I'm not sure if that's a perfect model for example, fetlock OA in a jumper or dressage, where the progression disease is much is lower. And unfortunately, is a quite expensive model. To run like this model, we're going to be talking about $500,000 problem. So probably, so we don't have a lot of data. I wish we could have all drugs test, in a model. And not saying that's the best model, I just think it's a model that's pretty reliable. And a lot of alternative, a lot of interventions have been testing this model, so it just makes sense to me to to be something to consider. So talk about the corticosteroids. These three corticosteroids have been tested in the carpotypo model. So the first one was betamethasone, followed by triamcinolone, and the methylprednisolone was the last paper. Which is important to note is just the between the betamethasone model was a little bit different than triamcinolone and methylprednisolone. So whenever they start to move forward with that model, they have to make some adjustments, and so they're very similar, but they're not identical. And I'm not quite sure if the severity is exactly the same for all three models, all three papers. So with that in mind, I'm gonna just overall summarize what these three papers found. So methylprednisolone was tested using 100 milligrams in a joint. Betamethasone was 48 milligrams, and triamcinolone is 12 milligrams. What they observed that is as a symptom modified osteoarthritic effect, so they didn't find actually improvement in lameness using methylprednisolone. It was better, but was not statistical significance. Betamethasone didn't also affect lameness, so the horse didn't get better or worse with lameness with betamethasone. While the triamcinolone, they have improvement in 1 grade in the lameness. So now, if you bring that clinically, I would say most of us would agree methylprednisolone and betamethasone in the joint probably produce some pain relief, as well as triamcinolone, right? But in the paper, they could not find that difference. Another thing is answer for us, 1 grade improvement in lameness, that's what you would expect, if you use that, model. Keep in mind the model is pretty hard on the joint. So looking more at the disease modifying effects, so we're going to break down in cartilage and synovial membrane. So synovial membrane histology was improved with methylprednisolone. There is no difference with betamethasone, and it was also improved with triamcinolone. Cartilage histology was actually worse with methylprednisolone, and this worse means there was worse than just the disease per se, just the control joint with the disease. Using the methylprednisolone was worse. Betamethasone was not difference between control and betamethasone, which means didn't help but didn't deteriorate the joint in neither. And Triathlon have been, show improvement on cartilage histology. So with that, we have been probably hear a lot about this thing that, triathlon is the good guy and methylprednisolone is the bad guy, or a lot of times you see, in the books and the papers called triathlon as chondroprotective. And that's kind of like, a question we need to further investigate. So is there really a difference between these two products, or there is something else could answer that, right? So if you look back actually from Dr. Macrae group, like a while back in 2003, they did an in vitro study and they compared methylprednisolone and triamcinolone. And what they figured out, there is no difference, at least in vitro, in these two drugs, and they didn't find a dose effects. So higher dose or lower dose didn't alter the effect on cartilage. So that paper didn't find a difference between both methylprednisolone and triamcinolone. This other paper also didn't find a difference between methylprednisolone, dexamethasone, and triamcinolone, and they didn't find a clear effect on dose as well. So it doesn't mean higher dose does a better job than lower dose. So moving forward, there is another paper that didn't see difference between methylprednisolone and triamcinolone on the gene expression in vitro as well. So keep it going. There is not a lot of difference so far in vitro, right? This paper comes and show us that, basically there's very little difference between dexamethasone and triamcinolone compared to prednisolone. But what I think was really interesting on this paper, that they found the lower dose of glucocorticoids could inhibit metalloproteinase without affecting the cartilage metabolism. And I think that's start to tell us that is maybe a dose effect on that. And more recent, there is this paper that look like equimolar concentration, so equivalent concentration of the methylprednisolone, triamcinolone, and they didn't find actually a difference between these two drugs. So they seems to be similar if they're using at similar concentration. And another thing that's very interesting is they found that lower dose actually have a better response than a higher dose. So keeping looking on the corticosteroid, methylprednisolone, and triamcinolone, these studies were done by the same group. So they use like very similar model. And what they did, they inject triamcinolone or methylprednisolone every other week for 3 times in normal joints and look for cartilage, biomarkers just to see cartilage metabolism. What they saw that both drugs actually affect the cartilage metabolism. You could eyeball here and say, well, maybe methylprednisolone works mass with the cartilage metabolism a little bit more than triamcinolone. Also, methylprednisolone seems to be affecting the collagen type 2 metabolism more than triamcinolone. But again, like they use 60 milligrams of methylprednisolone in this paper. They use only 9 milligrams of triamcinolone in this paper. So, but the overall take-home message is both drugs would affect cartilage metabolism on normal joints. So I put this paper here, more to try. It was one of the few papers I saw that I think was really interesting. They tried to see if there is, they tried to see a lot of things, but one thing I think was very interesting, they compared triamcinolone and methylprednisolone in a clinical settings, to see if there is difference between these two drugs to improve lameness in horse with hock OA or distal hock pain. And they didn't find any difference between improvement in lameness between two drugs. So now, trying to answer that question in the beginning, methylprednisolone doesn't seem to be more potent, or neither triamcinolone to be more potent on decreasing the pain in the hock. And again, they saw improvement in lameness in around a little bit less than 1%, 1 grade, improvement in lameness. So again, this doesn't mean that all the horse that get injected with triamcinolone get sound. Actually, in average, they get 1 degree better. And one thing they noticed that is horses with focal radiopharmaceutical uptake, they're less likely to respond to corticosteroid injection after 2 months. So that's another thing that bring to us as clinical experiences. What do we do if this horse that have a lot of subchondral bone or bone pain associated with the joint OA. So trying to summarize everything here in one single chart, I have the question, I have breakdown between metoprolol and triamcinolone, and I try to bring the level of evidence. So the first question is, intra-articular corticosteroids affect normal cartilage metabolism? And that's a yes for metoprolol, and that's a yes for triamcinolone. And I would say the level of evidence for that is probably moderate. So there is some good in vitro and experimental in vivo studies showing similar results. Another question is, intra-articular corticosteroids prevent cartilage degradation in vitro, and that's yes for metoprolol, and that's yes for triamcinolone, with the level of evidence is being weak because it's most based on in vitro studies. Corticosteroid prevent cartilage degradation in vivo, and that refers to that classical paper from Dr. McRae's group. And the answer is no. Metoprolol didn't seem to show improvement cartilage histology in vivo, while triamcinolone have shown improvement cartilage histology. And the level of evidence I put for that is like a moderate level of evidence, so it's an experimental study. Other thing is, higher doses have more clinical benefit effects. So do I need to use more to get a better response? And that seems to be no for metoprolol, that seems to be a no for triamcinolone. And the level of evidence is considered weak just because most of these studies were done in vitro. But if you see, there is at least 2 or 3 in vitro papers that goes towards the same answer. So it's a weak evidence because it's an in vitro study, but it makes at least all the papers seems to point the same direction. And that leads to the second question. Do we think that the chondroprotective effect or chondrotoxic effect that was saw, especially on that in vivo model from CSU group, could that just be dose dependent? And I would say that could be. So I would say yes, and however, the level of evidence is, it's low, it's a weak just because, again, we just have in vitro studies that show the higher dose have more chondrotoxic effect and, and then lower dose. And the last question is metoprolol better than triamcinolone to treat joint OA? And just based on that clinical study, I would say no. Even though it was a clinical study, I could say, oh, that's at least a case series with control group. There is some lack of study design. That's why I consider a more towards a weak evidence than a strong evidence, but would be somewhere between weak to moderate evidence on that question. So another question that a lot of people think is does intra-articular corticosteroid increase the risk of injury, right? I think that's a big hot topic now. Everybody discussed that, and that's a big concern for all the sports medicine clinicians. And let's try to answer that based on the the science. So we have this paper that was done in 2014, and they did find actually a correlation between local corticosteroid injection and subsequent musculoskeletal injury, and they didn't see any beneficial effect of local corticosteroid injection. There's another study that use even a bigger number of horses. Now we're talking about 1,488 horses, so it's a good group of horses. And what they saw is, yes, there is an increased risk of injury if the horse has been treated more than 3 times in a period of 56 days. And just going back here, that if you look this graph, that's almost exactly the cut line here. So about 2 months prior to the lesion, that's when the injections happened, right? But going forward with that, we're trying to look okay, so what's the reason for that increase in incidence of fractures? And most important, we don't see a detrimental effect of metoprolol on subchondral bone on the subchondral bone mechanical properties, right? So doesn't seem that the metoprolol is making the subchondral bone weaker, and that's why it's going on. So put that together, we can, maybe say there is a correlation between corticosteroid injection and musculoskeletal injury. Yes, there is a correlation, and the level of evidence of that, I would say it's probably moderate. But do we have evidence that corticosteroids cause musculoskeletal injury? And that's probably a no with a weak evidence, and that's just based on that experimental study that didn't see any effect of corticosteroids in the subchondral bone. So another question is like, does corticosteroids increase the risk of laminitis, right? And if they increase the risk of laminitis, is methylprednisolone safer than triamcinolone for the horse with like in a higher risk? And if it is safe, what's the dose, or there is a safe dose you can use in a horse that will not, give risk of laminitis? I think that's a big question. Like every time we, inject corticosteroids in a joint, we always worry about the horse have, laminitis. So we're gonna try to go back and see what we have as evidence, in the literature. And the first evidence we have is actually just pharmacological evidence, say that triamcinolone has a glucocorticoid potency much higher than methylprednisolone. That's where, like, the rationale behind the triamcinolone being worse to induce laminarity is because it's mess more of the glucose metabolism, mess with the insulin sensitivity, and that's what's going on. And that would be worse than methylprednisolone. So that's just a pharmacological approach. To be really honest, we don't even know if that's actually how corticosteroids are correlate with a higher risk of laminitis. We don't even know if it is because the glucocorticoid potency, but that's what a lot of people keep in mind. Say, oh yeah, triamcinolone is worse than prednisone, to induce laminitis. Mostly is based in just the pharmacological evidence. So there is like few retrospective studies that look, triamcinolone specifically, in the risk of that to induce laminitis. And one, they looked 204 horses that received triamcinolone, like up to 80 milligrams of triamcinolone, and that's only one horse actually had laminitis that could be correlate with triamcinolone injection. And this horse had been treated for laminitis previously, so had a history of laminitis. Another study, retrospective study again, looked 2,000 cases, and just 3 of these 2,000 injections had developed laminitis. And from these 3 cases, 2 were ponies that had history of laminitis. So with that said, question is there a correlation between corticosteroid injection and increased risk of laminitis in a healthy horse? The answer is probably no, or at least not in that range of those who are talking about 40 milligrams per 4 milligram body dose, but it's still kind of like a weak evidence on that. The second is there's a correlation between corticosteroid injection and increase of risk of laminitis in horse with a history of laminitis, and that would tell me probably yes, based on that 2 papers, retrospective studies, and I still give like a level of evidence weak is just because they didn't have a control for horses that laminitis, no laminitis, and what's the odds ratio for a horse with laminitis receiving intrarticular corticotherapy developed laminitis, right? So there is a little bit of evidence there that maybe laminitis, intrarticular corticosteroid or corticosteroids could be a little bit more concerned in a horse with a history of laminitis, right? So how I take that clinically is if the horse is sound, healthy, never had historic of laminitis before, I would say like probably 40 milligrams is still like safe. If the horse had laminitis, I say that's probably not safe to use corticosteroid in this horse. And I don't think there is any evidence to say, oh, should I use methylprednisolone instead of triamcinolone? We don't know. We don't know if that's going to be the difference. Also, what if I use a very small dose? That's make any difference? We don't have that evidence neither. So I try to avoid corticosteroids in horse with a history of laminitis. So another important question is like, does corticosteroids increase the risk of joint infection, right? And if that is a yes, there is a difference between corticosteroid, like which corticosteroid is worse. And if that's the case, should I be using amikacin to inject corticosteroids? So this is a really nice paper, again, like a retrospective study, but it was nice because they were able to have like some control group. And if you see here, p-value between horse that developed arthritis after inject corticosteroids, it was not different. So the p-value was not significant. So that answered the first question. Seems like corticosteroids does increase the risk of joint infection. But it's funny because now we are like grouping all the corticosteroids. If they break down between types of corticosteroids in the paper, they claim that actually betamethasone had statistical significance difference between dexamethasone, with betamethasone have a lower chance and dexamethasone a higher chance of joint infection. So that's, you can see like p-value was significant there. So, and the other question is, okay, so if there is a risk, should I be using amikacin? And I think there is some evidence to point us that amikacin is not even in the dose that have been commonly referring the literature to put in the joint. Amikacin is very toxic to the cells. So if you see here, like concentration, toxicity levels, increasing quite high here. So amikacin is actually very, very toxic to the joint. So trying to answer that, is there is a risk of corticosteroid, increased risk of joint injections? No, and the level of evidence for that is moderate. And if corticosteroids, if you break down between corticosteroid types, which corticosteroid, small evidence that maybe betamethasone is safer than dexamethasone, but anything else is statistically significant from that paper. And the other question is, should I use amikacin when performing intrarticular corticosteroid injections? And so far the answer is no, with like in vitro evidence that amikacin is pretty toxic to the joint, and with the evidence there is no increased risk of corticosteroid inducing joint infection. So, another thing I see a lot of people doing is injecting the horse with blocking the horse, associate that with triathlon, with the way of, if the horse is blocked, he's already treated, right? I don't need to go there and inject the joint. So do we have any evidence that if you inject, if you associate corticosteroid with mepivacaine, does that decrease the corticosteroid, anti-inflammatory effect? In that paper, come with some conclusion that is no evidence that, associate mepivacaine with triamcinolone would reduce, the triamcinolone anti-inflammatory effects. And that's give us like, was a nice study, experimental study. So I give a moderate evidence. So that's give us that doesn't change much the efficacy. On my mind, the way I see that paper is more, I don't adopt the, I blocking in, with my block, I put corticosteroid in case, that was the problem. Because if you remember in the beginning, we talked of normal joints, corticosteroids can be toxic, right? So in this way, I try to avoid corticosteroids in joints that are not need corticosteroid. What that changes for me clinically is if I block the horse one day and I want to treat in the same day, which I have seen people not doing that because they're not sure if you inject the horse, treat the horse the same day that we block, the anti-inflammatory effect will be the same, right? So I use that paper to answer that question. I don't think there is a problem. I think we can always treat the horse in the same day you block the horse, and you're probably going to have the same clinical benefit from the corticosteroids. So going a little bit about the hyaluronic acid, it is something that we need to discuss if there is evidence to use hyaluronic acid to treat joint OA. If there is any, benefit for the pain for the limbs, if there is any symptom modify OA effect, does hyaluronic acid or polysulfate glucosamine going to affect this? If there is any disease modify effect, and if hyaluronic acid can mitigate the detrimental effect of intrarticular corticosteroid. Actually, a very common use for the aging these days is like, you're injecting corticosteroid, the corticosteroid can be harmful for the joint, so you put some AJ, kind of like trying to counteract that. So that's the rationale that I see a lot of people using. And we're going to try to answer that. And, does it have in translate does that translate to clinical benefit? So by adding hyaluronic acid to transferrin injection, does that make the horse clinically better? So one of the first papers, like 1995, that compared like glycosaminoglycan, polysulfatato glycosaminoglycan, and sodium hyaluronate with placebo. I think it was super nice because actually it was a clinical study done really well designed, in 1995, and seems like we have less and less of these nice papers. And what they notice, yes, there is a symptom modifier, so the horse tends to get better or less lame using polysulfatato glycosaminoglycan or hyaluronic acid in the joint. So there is some improvement in lameness. When you look the experimental study that was done at CSU using the carpal tunnel model again, they compare hyaluronic acid, polysulfate glycosaminoglycan, and the control. And basically what they said, they have a tendency to improve lameness, and they, I would say, like polysulfate glycosaminoglycan, if you look here, was better than just placebo. But not statistical significant, right? So it's probably, and if you look here, this whole the magnitude of effect is probably less than like half grade in lameness. So if there is a clinical effect, it's very minimal here. Now, what they notice is there is an improvement on the cartilage fibrillation for the hyaluronic acid. So hyaluronic acid had a better score for cartilage fibrillation, while polysulfate glycosaminoglycan had a better score for synovial membrane histology. So basically, we can take that is if you're treating a synovitis, polysulfate glycosaminoglycan would probably have a better effect over the synovial membrane, the AJ. And if you're talk about treating more a cartilage fibrillation, or if that's your concern, AJ could have a better, improvement there. Recently we have this paper come out, is a systematic review. That's what we know, kind of like discuss one of the highest level of evidence, and it was done for the group of Dr. Zopa in São Paulo. And they conclude that there is no great evidence of benefits, treatment, protocols, or mechanism of action of hyaluronic acid, injections in horses. And that goes in agreement with the human literature. If you look the human literature, there is no evidence that hyaluronic acid should be used to treat joint OA. And if you look the recommendation of the Academy of American Orthopedic Surgeons, they make a strong statement there is no evidence of benefit use hyaluronic acid to treat joint OA. So that's kind of like goes towards my clinical point is I personally don't inject a horse with only hyaluronic acid if I'm trying to treat joint OA. I don't think we have evidence. I think we have better things now that can bring something to the table that's better than hyaluronic acid, right? So do I still use hyaluronic acid? Yeah, I do still use hyaluronic acid, and basically, with the idea that maybe that's helping a little bit, counteract the negative effects of corticosteroid in the cartilage metabolism. And that's what this paper saw, that if you inject transferrin with hyaluronic acid, you have an improvement on the cartilage metabolism. Consider methylprednisolone. That was a little bit more inconclusive because they have actually 2 studies looking methylprednisolone associated with hyaluronic acid. And what they found is if you looked at in cartilage explants, you don't see a lot of effect. If you look just in the chondrocyte model, right, or culture, seems like that has a higher benefit using the chondrocytes. So that was a little bit inconclusive to me. So clinically speaking, I think this study was really nice. They now include 80 horses, and they look primary outcome was clinical success, which is defined by improvement in at least 2 grades of improvement in lameness. And they look the horse, baseline 3 weeks, and they have a follow-up at 3 months to see how the horse were doing. And what they saw is actually the likelihood of success. So there is 87% of the horse that receive only triamcinolone were better at the 3 weeks evaluation, compared to only 64% of the horse that received triamcinolone hyaluronate, and that was statistically significant. However, at 3 months and follow-up, there is no difference between the 2 groups. So what that tells me clinically is basically, if you inject only triamcinolone, you're probably going to see a quicker clinical response, but that's not going to be significant at 3 months. At 3 months, both groups probably going to have the same clinical response. So in summary, we can say that, question about, is there any symptom modifier or assorted effect? And I think that's inconclusive for both. So in the level of evidence, it is weak, especially because we have couple papers showing one direction, other papers showing the other direction. It's just inconclusive. We cannot make any assumption on that. Is there any disease modified effect? And I would say yes. And I quote that paper from CSU. But again, I'm gonna put that the level of evidence of that is probably not as low. It's probably could be a moderate level of evidence. What I think is how clinical significant is that evidence, right? How much that disease modifier effect actually translates clinically. That for me is not as significant as if they have or not this effect. The other question is can AJ or polysulfate glucosamine mitigate the detrimental effect of intrarticular corticosteroids? So AJ seems to be helping with that. Polysulfate glucosamine was not evaluated. And the level of evidence, again, it's in vitro studies, right? So there is few in vitro studies that look into that, and they point to same direction, but it was still, again, in vitro study. And does it translate to clinical benefit? So far, no. Based on that paper that discussed about race horses that get triamcinolone or triamcinolone AJ, doesn't seem that make them any better. And the level of evidence for that, I would say it's moderate. So talk about biologic therapy. I want to see what's the evidence for us to use PRP, IRAP, autologous protein solution to treat joint OA. And again, the question is going to be similar. There's any symptom modifier effects, there's any disease modifier effects, and how they compare to each other, right? So moving forward, anyone that interested on PRP in joint, I would recommend to look at this paper. That's a systematic review that comes from the group in Brazil. Dr. Bacarin wrote this paper. Her group wrote this paper, and it was really nice. And this paper, I used to base my arguments here. And in this paper, they see that from 11 clinical trials done in horses, only 3 were concerned about joint diseases. Now, all the other 8 were looking for soft tissue injuries. And from the 13 experimental study, only 3 were associated with joint and none look actually symptom modifier effects. So it is very interesting to see there is a good number of papers, but there's very little evidence in joints, right? And it's super easy for us to translate whatever we find, or if that helps tendon healing, that should help with joint, but then not necessarily the case. So, one of the papers, and this paper, I never could find that as actually, a peer review paper that was published as proceedings in one of the World Equine Veterinary Association conference. And they found they get 42 horses. It was nice because they have 12 horses that have as a control, and they enrolled 10 horses with acute OA or acute pain, and 20 horses with more a chronic case of OA. And what they found is the return to athletic performance was basically similar between all groups, so everybody returned to sports. However, 33% of the control horses actually were not able to keep full work, while just less than 10% of the PRP horses were back to were not able to sustain training. So, another thing they point is the chronicity and radiographic changes were negative predictors to the response to therapy, which is another thing we need a lot for a lot of the therapies we do, is start to break down, chronicity of the disease and radiographic change to see if there is anything can point us to see which is the best, therapy to use. So this is another paper that come up, and they're trying to look PRP after in horse of natural occurring joint OA, and if you see, they have from 10 horses that block to the joint they were looking, only 3 respond to PRP injection. So that's kind of brings more there's a small percent of the horse that's actually going to improve with PRP injection. At least that was kind of one of the points on this study. And again, they didn't find any correlation between if the horse blocked to the joint and if they respond to PRP or not. And, they didn't find a correlation between radiographic OA and response to PRP. So kind of a little bit different from the other paper. Now, the radiographic change of OA was not correlate with response to PRP. So that's another paper from Dr. Carmona. That was looking, I think, if I'm not wrong, this is just 7 horses, is a preliminary pilot study, and they saw improvement in lameness. There is no control group in this case, so they saw the horse get no injection beginning. In the final evaluation, the horse get sound, and if not wrong, the final evaluation was 90 days later. So that shows a little bit of symptom modify effect, improving degree of lameness and joint infusion. So this paper is another interesting paper that trying to look the effect of blood derived products. So they look PRP, IRAP, and a few other products, but I'm going to keep PRP, IRAP, and trying to kind of see if you can compare each other. And the PRP and IRAP for horses after arthroscopy surgery to treat osteochondric lesions. And what they found that PRP actually have a little bit increase on prostaglandin E2, 48 hours after the injection, compared to IRAP that actually decrease the inflammation. Both therapy increase the interleukin-1 receptor antagonist, and again, both therapies seems to be beneficial effects on the chondroitin sulfate metabolism in the joint. Another paper trying to compare PRP to IRAP, and they look there is actually 3 forms of PRP. Basically, they're platelet concentrate. They have a detergent treat platelet concentrate, and they have a platelet lysate, and they have one group of chondroitin sulfate. So you see, depends which growth factor you're looking for. There is a difference between these products, right? So PRP and IRAP, they have a different composition on the growth factor profile. With PRP, with IRAP, creating a little bit more interleukin-1 receptor antagonist protein, and as on the other side, platelet lysate actually have the highest value of IRAP protein present in the product. No other product show interleukin-1 receptor antagonist protein. So the anti-inflammatory protein of the IRAP was also found in platelet lysate in this paper. So as we're talking about the autologous condition serum, or IRAP, it's how it's now marketed. We're going to look in this paper that was done by the group, Dr. Friesman, the group at CSU, and they looked carpet tube model. So we're going to see symptom modify effects and disease modify effects, right? So one thing they saw is there is a symptom modify effect of IRAP, in the horse, with the horses that are receiving IRAP being better clinically at 7 days of the experiment, right? So it's at least 2 months after the experiment, the horses are clinically better. And that's kind of like one of the explanation for that is that actually there is an increase on the endogenous IRAP release. So you treat the horse with autologous conditioned serum, and you're not only delivering the growth factors and the cytokines, but inducing a release from the synovial cells to produce the anti-inflammatory protein, and that was significant at 71 days. So we have like now a peak on the anti-inflammatory protein at 71 days. So the body is actually producing IRAP at this point. We just don't know how long that would last, right? So is that would keep going or not? The model is usually 70 to 90 days, so that's the end of this study period, right? So we don't know how long that would be, and if it would increase or drop. But they note there is improvement cartilage histology, and they note there is improvement on synovial membrane histology. So they conclude there is a disease modify effect as well on this of this drug. Another product that's being used more recently here in the United States is called autologous protein solution, or the commercial name is Proistride. And that product get a lot of popularity in the recent years. And most of people refer to this paper, right? So this paper was done by the group of Dr. Bertoni. And what they notice is there is an improvement in lameness after injection of just single injection of this autologous protein solution. There is improvement in lameness at 7 and 14 days, and that was detected by like subjective analysis, and that detected by biomechanical force, kinematic analysis, right? The problem is this study didn't went further here, and all the horses after, if I'm not wrong, after the 14 days, all the horses were treated with Proistride, and then were evaluated, through a follow-up to see how they do over the time, and that's where the clients is scoring improvement compared to baseline. And they notice there is a sustained improvement of these horses over a period of 1 year. What I think is important to notice is all the horses here is already treated, so there is no blinding. We're not protect against bias, right? Which is the biggest issue that I see here to make a long-term like a long-term effect of this improvement in lameness observed at 14 days. So that's kind of like how I see that data. So that's basically the paper we have talked. So it's kind of like they're looking the several growth factors on autologous blood products. So they are comparing the IRAP and the Proistride, and they're basically similar here, right? So if you look the Proistride and the IRAP, they're similar in the cytokine concentration, which is important to understand. Now we're talking about cytokine concentration. When you look in vitro studies or analytic studies like that, they give us concentration of cytokines per ml of product. Clinically, the biggest difference that I see here is one product is going to give you 24 mLs of final product, while the other one's going to give you 4, right? So that's kind of like a point when we start to see how much you get for each kit you're going to use. So said that is just like a brief overview of like the biological therapy was being done in humans and in horses, and there is very little evidence of like how these therapies compare to each other and compared to the standard of care, which would be hyaluronic acid. So I'm gonna quote here 3 papers that was done in humans, and they evaluate PRP, IRAP, and prostride in humans, and they're able to do this randomized clinical trial. So this first paper was done by Dr. Brian Cole. He's a human surgeon, one of the most famous, orthopedic guys in this field. And Dr. Lisa Forter from Cornell is also an author in this paper. And what they notice is there is improvement on the IKDC score over time, up to 52 weeks after treatment of platelet-rich plasma, when they compare that to hyaluronic acid, right? So seems like the patient is doing better than if you just inject hyaluronic acid. But keep in mind that even for humans, hyaluronic acid is not considered like super strong or super potent intervention for joint therapy, right? So it's kind of, there is some improvement there. They're not better in the WOMAC, which is another category to score joint disease in humans. But if you use the human as a model, kind of like different than we always do. We always use the horse to model for humans. But if you get this data and translate back to the horses, PRP seems to be a little bit better than hyaluronic acid in the joint. This another paper that's now done with autologous conditioned serum, and basic same model, randomized clinical trial. They have a big population of patients. They have 310 patients, and this paper they follow up the patients up to 108 weeks after intervention, and they saw WOMAC score, a difference between the patients that receive hyaluronic acid or saline solution to autologous conditioned serum, right? So if you see hyaluronic acid here is basically the same as placebo, right? And that's what's kind of bring up for me the discussion of the previous paper that they use hyaluronic acid. Hyaluronic acid in this case is basically a placebo, okay? And here lower score is better, so the autologous conditioner did better. More recently, they have this paper in human that show it's similar model, but they show the use of the autologous protein injection in human knee, and they use WOMAC as a outcome. WOMAC is a very common questionnaire that is used to evaluate human patients with knee problems. And they notice there is improvement of the patients up to 12 months compared to, again, saline solution. So based on that, I think the question is there any symptom modifying effect of PRP, IRAP, or autologous protein solution? So I think PRP is still inconclusive. We cannot say if PRP helps with lameness or not. IRAP, I think we can tell that based on some of the experimental studies. And APS also, with in mind that APS, the only improvement in lamina was in a very short period of time. So it is just keep that in mind, that maybe we don't know how that would sustain over a further period of time, and that would say it's probably a moderate evidence of level of evidence. Is there any disease modifying effect of all these 3 biological therapy? And to be honest, the only one that has been evaluated was IRAP. IRAP has been evaluated using the carpotype model, and they observe a disease modifying effect. However, it was mild. If you look the magnitude of the effect, it was a mild improvement on the disease progression. But experimental study, so it's a moderate evidence there. And another thing is disease state affect the clinical efficacy of this therapy, and the only one they have seen is since PRP, they look into that, but it was inconclusive. Anything else is was not evaluated yet, so that's a point to consider. Just make a note here, when you consider the human papers, most of that papers were done in human patients with Kellgren OA grade of 2 or 3. So it's kind of a moderate grade of joint disease, okay? So it's not mild for sure. So we're kind of more in the moderate and severe case of OA if you compare to what we have in horses. So, you could say, well, based in the human literature, these drugs might gonna help, clinically, even a moderate stage. So another therapy, being kind of like popular is the polyacrylamide hydrogel. It is a high molecular weight hydrogel, synthetic hydrogel that doesn't degrade in the joint as quick as would hyaluronic acid, for example. And people are using that, more and more frequently. And the questions about that therapy is there any symptom modify effect? And if there is any disease modify effect of that therapy? So there is few papers, on that, and we're just kind of like, starting to look into that therapy more. But yeah, like I would say, like, this paper showed like, a significant improvement in lameness using polyacrylamide hydrogel. So see, there is about 2 grade improvement in lameness for most of the horse, except for the horse with like, the highest level. So here is degree of OA. So the most severe effect horse didn't tend to respond as well, but from moderate to mild, the horse seems to be, respond quite well. If you remember, improvement in lameness with corticosteroids is about 1 grade that we have seen, on that's the evidence we have so far. So now we're talking about improvement in lameness at 2 grade, right? So that was one paper. And they also look like, what the hydrogel does to the joint, and they saw there is like this big difference on the synovial membrane. So 14 days after inject the hydrogel in the joint, the hydrogel tends to kind of like, come and cover the synovial membrane, and after a couple months, the hydrogel start to be more integrated with the synovial membrane. So if you look the synovial membrane histology, the scores goes high. I mean, there is a little bit more change there. If you look the cell count, like on synovial fluid, that is like, the levels goes back to normal, couple months after injection. And this basophilic staining is basically what they're seeing here is the hydrogel impregnate in synovial membrane. So that seems to be a constant find in these studies. And basically saw the horses like, again, improve lameness and was safe. So there is another study that was like, looking for symptom modify effects. And again, the horse tends to better. There is a more percentage of basically all the horses respond really well up to 24 months, right? So if you get here in this graph, you have like distribution of lameness, grade 1, 2, 3, and 4 at time 0.0, and all the horse get treated, and now they see all the horses now becoming better, and that's sustained up to 24 months. That was the study. Unfortunately, there is no control group, so we don't know if a control horse here would be better there or not. So in summary, what I think about polyacrylamide hydrogel. So is that safe? Yes, there is some evidence that shows that's safe. So I would say probably moderate evidence. Now there is no this few papers showing that. Is there a symptom modify effect? Yes, I think there is 2 papers showing that. There are case series, so we could consider maybe a level of evidence, maybe moderate, maybe less than that, because there is no control group. So it's kind of like between weak to moderate evidence. I think the biggest point is like just the magnitude of improvement is significant. It's 2 grade improvement in lameness, and that was for me, like, consider all the therapies we're talking here, that's definitely is, one that show the strongest improvement in lameness. Is there any disease modify effect? There was not a look, and I hope we're going to be, start to see papers trying to answer this question soon. And is there any detrimental effect to cartilage? Again, we don't know. We have no idea. Some papers need to come now and try to answer that question. So just try to finish here, not be too long on this presentation. I want to cover a little bit use of biphosphonate to treat joint pain. We all know kind of like use biphosphonate to treat navicular bone disease. But there is some evidence that we're going to discuss here, like maybe that could be useful to treat joint disease or joint pain. And the question is, there is any symptom modify OA? Is there is any disease modify OA effects? And does biphosphonate actually affect bone metabolism? So just bringing it up to you guys, that's a meta-analysis, and meta-analysis is the highest level of evidence, in human literature that use biphosphonate to treat osteoarthritis. And what they conclude, yes, that is, some evidence that biphosphonate is effective in relieving the pain, stiffness, and acceleration functional recovery of OA. So that's why, I bring that idea to treat, horses. Say, well, that seems to be working well in humans. That would maybe work in horses, right? So that's the classical paper from Dr. Denua about the chilodronate, and we can always, we can all appreciate here the horse get better, with the 1 milligram per kg, chilodronate injection. That was really nice. I think it was a really good study, well designed. So shows like that is definitely some improvement in lameness. And the question is, how safe is these drugs? And that's one of the points. And you're going to see that they're reasonably safe. Just be careful with a high dose of chilodronate using intravenous regional limb perfusion can hit concentrations high enough to be toxic for the cartilage, right? So that is this kind of point. But if you use intravenous regional perfusion of a low dose, you probably don't have the same issue. So the question about, does chilodronate change bone metabolism? And since that's not, that's another study that was done, and they didn't see a lot of difference in the bone metabolism using chilodronate. And this is another study that comes and basically showed the same thing: is chilodronate, or this case was cholodronate, they help with the pain, but they don't seem to affect the bone turnover, or at least we're not able to detect the bone turnover, yet. So if they do affect bone turnover, it is in a level that we're not able to detect that, in an experimental setting. So the question is there any symptom modify effects for biphosphonate? I would say yes. They definitely make the horse feel better, and I think there is a strong evidence of that. I think there is this analgesic effect. Does biphosphonate change anything on the disease progression? We don't know. We still need to further evaluate that. There is some evidence in humans, but again, most of the papers that were done in humans just look for the pain component. They didn't look for the cartilage disease progression component. So that's another thing we need to look into. And the question is, does biphosphonate affect bone metabolism? So far, seems like they don't. I would say we have a moderate evidence of that based on some clinical experimental studies. So that's basically my notes. Clinically, I do like to use chilodronate or chlorodronate for treatment of joint disease, especially if I have MRI and the horse come with significant bone edema, or if I suspect the horse has bone edema. Does that use that I do have any support from the literature? No, because we don't know if they actually chilodronate or chlorodronate, biphosphonate in general, affect bone's metabolism, right? So maybe the benefit that I'm seeing is just the symptom modifier way, it's just the analgesic effect of biphosphonates. So just trying to summarize everything, quickly here is what you still need to learn, right? So I would say corticosteroid therapy is still kind of considered standard of care. And that's kind of like another thing we need to bring to the research side. If you want to compare therapies, we should compare to, instead choose placebo, maybe choose corticosteroid injection, as right now I think most of the clinicians say that's probably standard of care. But we don't know if corticosteroids therapy have a different response in different stages of the disease. That's something we definitely need to know. We don't know what's even the ideal dose, right? We don't know how much put in the joint. Everybody does a little bit different. What we have evidence so far, especially in vitro studies, lower doses is probably as effective or more effective than higher doses, and they're probably less harmful to the joint. So after studying that part, I start to use lower dose that I commonly use. Is there a minimal interval between injections? Like, that's another thing. Like, if you ask several clinicians, everybody gives you a different opinion. How long do you wait until you inject the same joint of corticosteroid again? And it is 6 months, is 4 months, is 3 months, is a year. No one knows, and we definitely need to know. The pharmacological effect is different than the clinical effect, right? So the pharmacology, how quick the drug is removed from the joint is way quicker than the remaining clinical effect, and that's what we still need to learn. When it would be acceptable to inject the joint again, and there is a really beneficial effect of mixing AJ to corticosteroid injection, especially thinking in a cost benefit. So I would not probably even say clinical benefit, but it is cost effective using AJ and when you injecting corticosteroid. And that's another answer that needs to be you need to get it like soon. It's kind of like I still using, but if the client say, hey, like money is a little bit tight, I'm happy to inject the horse without AJ. And to be honest, I don't think the horse is losing a lot. About biological therapy as well, but biological therapy, there's so many questions, right? So I'm just trying to to take few ones here, but there's so many questions you need to learn, right? So are they any better than standard of care? I think that's the first question I need to say. Hey, is any of this biological therapy you're using better than corticosteroids? We don't know. Do PRP in autologous protein solution have disease modify OA effects? We don't know yet. We need to get a study design able to prove that, because so far the only one that showed disease modifying effect is the IRAP therapy. So that's like, if you go with the evidence, that's what the evidence tells you. Another thing when you talk about the difference between biological therapy is, should I be looking into concentration? So do I worry about which product give a higher concentration, or should I be worried about the total amount of cytokines I'm going to get, right? Especially in the joint, if you consider that therapy they're delivering to the joint is going to be diluted by synovial fluid, right? So when you look at all these in vitro studies, they are compared using the same concentration of biological therapy in the PET dish, right? The problem is in the joint, the concentration is going to vary about how much synovial fluid has in the joint and how much product you put in the joint. And if the way I look is, it's more like a total amount of protein I get per biological product. That's what's the reason I'm still using. One of the reasons I'm still using IRAP is just because, for me, it's the only one I have been showing disease modify effects. And I usually get somewhere between 20 ml, sometimes 24 ml of product, which I can use to inject the horse multiple times in multiple occasions. So I still think I get more to the buck, but we still need to kind of figure out what's the most cost benefit. What biological therapy has the most cost benefit on that. Another thing we don't know when we should use biological therapy, which stage of joint disease. It's really common for us. wait a little bit too long to start to use the biologic therapy, especially because the cost. But if we are using biologic therapy because the disease modify effect, I would probably argue that we should probably start using earlier, because when there is no cartilage, I don't think make any sense trying to put any of this biologic therapy, because we are not going to regenerate cartilage. We are not able to do that yet. And in the other sense, talk about how early start. Is there any benefit to use biologic therapy prophylactic, right? So in a horse that you believe that actually has problems or has propensity to have develop OA on that joint, should I use? And we don't know. We have the evidence of disease modify effect, but even that is still far away from answer the question of a prophylactic use of this kind of therapy. About the acrylamide hydrogel, the first is we need to be able to answer how they work. I don't think we still need to collect data on symptom modify effects, but we definitely need to look more into the disease modify effect. I think we're reasonably safe to tell that polyacrylamide hydrogel has improvement in lameness. It's just more how that works, and and does that protect the joint. And the question is, when should I use that? Should I wait until the joint is totally gone, or should earlier, or too early is maybe not great? We don't know when to use, right? So clinically, I tend to hold on this therapy until the horse fail at least one of the other interventions, just because there is a little bit more questions to be answered. Not necessarily about the safety. I think there is some evidence about the safety of this product. We just need to understand how that works and what that does to the cartilage itself. And can we use that, in a prophylactic way again? Can you use that even a horse that doesn't have a problem? So with that idea, you're going to keep lubrication of the joint. That's going to prevent OA. I think that's going to be answered if you able to show any disease modify effects of this product. And finally, about biphosphonate, and now I'm talk about chlorodronate, children osphos. One of the questions I have, do they help with the progression of OA? Makes sense knowing that the subchondral bone is a big part of the progression of the OA, but does that drug does anything for the joint? Biphosphonates does anything for the bone, and after that they're going to do something, following that they're going to do something for the joint. I don't think we have that answer, and we don't know how frequent, and if for long-term use would be detrimental for the joint. So that's kind of few questions still need to learn. Think that's basically it. After talk
yeah.
a lot. So happy to answer any questions
Doctor,
you guys have.
I'm going to make some. I'm going to make
Yeah.
some questions for the persons here in the meeting. One of those is about your opinion about pentosan or adequan, an experience with pentosan polysulfate.
Sure. Yeah, I didn't go a lot of details on this help support therapies, just because there is so much outside there. We would spend another hour trying to find evidence based on that, right? About a generalization would be pentosan seems to be better than adequan. So my based on what I have read, all the research I have done, or the study I have read, and I say research, literature research, right? In my mind is pentosan is the better. Legend IV is good. Polysulfate, glycosaminoglycan, intramuscular doesn't seem to do a lot.
Questions is What do you think about the use of biologics like PRP together with HA and polyglucosamine lichens, polysulfate glucosamine lichens at the same time?
Perfect question. That's actually something that I'm interested to study. If you look the human literature, there is, if I'm not wrong, there is like 4 or 5 papers that look AJ and PRP, and seems like for NeoA, AJ and PRP was better than just PRP. For some reason, seems like for HippoA, AJ and PRP was worse than just PRP, right? So it's kind of like a little bit conflicting results there, but overall seems that AJ associated with PRP has better clinical effects than just PRP or and now I'm making the extrapolation for IRAP in Prostride or APS. Clinically, as I don't use a lot of PRP in the joints, I kind of like a little bit worried about the high concentration of TGF beta in the PRP. TGF beta is a growth factor that is anabolic for the chondrocytes, but in a higher dose, you can induce joint chronic joint OA just injecting TGF beta. So I don't use PRP in joint that much. I use IRAP, and I have been associate IRAP in hyaluronic acid before. It's not my standard of practice, but I have been used before. I have been used actually for tendon shift before, and makes you feel good, but definitely we don't have the answer. If you're going to use whatever it's in the human literature to base our answer is, yeah, seems like that's helpful, but it's still a lot of questions, or a long way to answer, to be able to prove that yet.
Okay. And what do you think about estanosolol?
That's a hard one. So I would say stanozolol intra-articular, right? That is a paper that look into that. Actually, the results of the paper were like pretty decent. And as much as I remember from the paper, I read this paper a while ago, and I think that the paper shows some pretty decent data there. The question is, go back to, do we need to use stanozolol? How that compare to other therapies? And all these things, and go back to like we work with sport horses, doping, all these regulations, right? So I don't have the experience. I think there's a rationale behind. I think the data that was presented was reasonable, but it is something that here almost no one talks about, just because everybody's so worried about create many of kind of like regulatory issue.
Okay. What do you think about, and which is your experience with stem cells, umbilical cells, or placentary cells?
Let's say I'm going to generalize that to stem cells in general to treat joint OA. My clinical experience and my clinical thought is I didn't get results yet that justify the cost to use them over use the other biological therapy. I don't know if that makes sense, but for me, the effects of stem cells in the joint, in joint OA specifically saying, didn't have tell me that they're much better, to be able to tell the client you should be spending like 3 times more in stem cells to treat your horse than using biological therapy. So I think that's kind of like the evidence is lacking. Is again, we need to compare these biological therapies one to one, like see, we just make bold generalizations about, I want to know about PRP against IRAP, against Prostride, against a stem cell. And when you go about stem cells, there is this huge gamma of products can use from autologous, allogenic, So it's just kind of like start to go too many variables, and in this case, kind of like it's going to be really hard to actually create a constant answer on that. Unfortunately, I'm not sure how the experience you guys have, but recently here in the United States, there is so many companies offering amniotic stem cells, umbilical, all these things, but there's very little data on that. So it's kind of like they get in the commercialization part way before they're able to prove even safety, to be honest. So I don't go that. When I use stem cell, I use autologous stem cell from bone marrow.
Okay, another question is, what do you think about the use of intravenous HA?
Good, good. The intravenous AJ, the legend, that's the same as I know. I was talking with Pentozone. I believe it's a little bit less efficient than Pentozone. I think it's better than Adequan. Since I know clinically, there is a place we go basically every year is a high level dressage barn every year, every week, and they tend to use a lot of legend there, and seems like the horse is lame, and they do legend, and we are there like a couple of days after to see the horse, and the horse is not lame anymore, right? So seems to have like some good symptom modify effects there. The paper seems to help with the synovial membrane histology. So it's kind of like I like, but I know it's expensive. I know it's not every client, every horse can be on that. And again, I don't know if you can justify the cost, to be honest, right? So if you want to do like high level horses going to to show this now in 2-4 days from today, and you just want to be sure the horse is going to be fine, I think that's fine. Clinically, that's kind of like how I feel too. But it's really hard for me to make a really strong statement on potency and all these things, just because there is very little data on that.
And the last question is, have you used prolotherapy in joints?
Well, prolotherapy is basically whatever you put in the joint that's gonna create more inflammation and gonna make your body counteract that inflammation and enter in a like anti-inflammatory stage, right? So that's the base of some of the prolotherapy, at least. And to be honest, I don't even know if you use a high leukocyte PRP, that could be considered maybe a prolotherapy as well. I don't have use. I have here people use dextrose intrarticular to treat like severe case of synovitis in humans. There is some evidence there. There is not in horses. I didn't have go that far yet, but I do believe when you're getting that end stage of joint disease, there is nothing else you can do. You just need to control pain. I think something we should consider now is just need more data on that. We just understand how and when to use.
Okay. Doctor, I just want to say thank you for your time, for your awesome conference, for your knowledge, and everything you shared with us. Thank you again, and we hope have you here as soon as possible.
Okay, great. Thanks so much for everything. Thank you for inviting me, and let me know if you guys need anything.
Okay, thank you, doctor. Have a nice night.
You
Bye
too.
bye.
Bye bye.
Thank you.
Bye.